everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to thank you for joining us for today's webinar, Referrals on the Rise, Strategies for Improving Timely Organ Referrals. Before we begin today's presentation, there are just a few reminders that we'd like to review with you all. For optimal visual and audio experience, we do recommend accessing these browsers in the Chrome browser. If at any point you encounter any issues, please log back in using Chrome. If you're already using Chrome or continue to experience any issues, please dial in using the phone number that was provided in your confirmation email. To those of you who are just joining us for the first time today, please take note of the chat feature that is located on the bottom left-hand corner of your screen. This chat should be used to pose your questions to our speakers. If you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, for those of you who may be interested in our upcoming webinars, please note registration is currently open for our next webinar, Innovative Donor Management in In-House Recovery Centers. That's coming your way on September 19th at 2 p.m. Eastern. Registration is also open for our upcoming transplant webinar, Living Donor Liver and Kidney Transplantation, Pushing the Envelope by Changing the Paradigm. Be sure to join us for that on September 26th at 3 p.m. Eastern. For more information on these webinars or to register, please visit our website at organdonationalliance.org. Now, for anyone who is interested in obtaining continuing education credits, we are offering 1 CEP-C credit and 1 nursing contact hour for this webinar. Please note we are also offering a certificate of attendance. So for anyone seeking CEs that are not available, we do recommend submitting a certificate of attendance to your credentialing organization as proof of your participation in this educational offering. Everyone joining us today is entitled to claim either of these credits or certificates. Prior to receiving your certificate, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, for nursing, you'll have 14 days to complete your evaluation and claim your credits, and for CEP-C, you'll have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Kathy Warhola, Regional Hospital Development Coordinator at Lifeline of Ohio. Kathy, it's such a pleasure to have you with us today, and at this point, I'll go ahead and turn it over to you to introduce our speakers.
Thank you very much. Our speakers today are Andrew Mullins, who is the Chief Operating Officer for Lifeline of Ohio in Columbus, Ohio. He's worked in organ, tissue, and eye recovery for almost 20 years. He was Director of Hospital Development and Community Education at LifeNet Health in Richmond, Virginia, also Director of Ocular Services at Lions Eye Institute for Transplant and Research in Tampa, Florida. And at Lifeline of Ohio, he has served as Director of Recovery Services and is currently Chief Operating Officer. Our second speaker will be Ann Willingham. Ann is a donation system specialist for LifeGift in Fort Worth, Texas, and has been involved with hospital development and family care for over 9 years. In addition to working in the OPO world, Ann has been the Director of Kidney Transplant Services at University Medical Center and Executive Director of the Great Plains Lions Eye Bank in Lubbock, Texas. Ann has used her 23 years of donation and transplantation experience to empower hospital teams and develop critical care staff to navigate difficult situations and manage obstacles in the donation process. Our third speaker is Mike Eckhard. Mike is an experienced Chief Nursing Information Officer, a board certified in both nursing informatics and advanced executive nursing leadership. She holds a master's degree in nursing administration and 30 years of nursing experience spanning multiple clinical areas. We're so pleased to have all three of you working with us today. Welcome, all three speakers. I will now introduce Andrew Mullins, who's our first speaker.
Great. Thank you, Kathy. And I'm going to start off just kicking off, just laying some framework for why the importance of the early referral. Just a little bit about Lifeline of Ohio. We are an independent nonprofit organization serving 37 counties in Ohio and 2 counties in West Virginia. We have 78 hospitals that we partner with, including 2 transplant centers, the Adult Transplant Center, the Ohio State University Wexner Medical Center, and our Pediatric Transplant Center is Nationwide Children's. Our overall population of our DSA is 3.4 million. So just to let you know kind of where we're at and what we've seen and kind of where we're going, you can see on this chart, we've seen a 4 consecutive year increase in the number of eligible deaths from 2015. And then all of a sudden in 2019, so this chart that you're looking at is through January 1st through August 18th for 2019. You can see we've seen a decrease in eligible deaths of 31. But we've also seen an increase in DCD, and there's many things that are sort of happening there. The one key is it's not a matter of hospitals not declaring brain death. One of the biggest things that we're seeing is really a timeliness factor. And we've had 13 cases since the beginning of 2019 that we started as DCDs that converted to brain death. So we're seeing a lot more families making the decision much earlier in the process. You can see also a huge increase in the DCD approaches that we've had since 2015, starting with 23 DCD approaches up to 78 in 2019. Overall, if we take this through August, we're only down 2 organ donors compared to where we were at through last year. We've seen 3 consecutive record-breaking years in the history of our organization. When you go down to the bottom part of this chart, you'll see one of the biggest decreases in eligible deaths is where it says Mount Carmel West and Grove City. Mount Carmel West closed in April of 2019 in a brand new hospital. They opened a brand new hospital called Mount Carmel Grove City, which is about 10 minutes away from the old hospital. And with that, the eligible deaths that we were seeing at Mount Carmel West, they're not showing up at Grove City 10 minutes away, and we're not seeing those reflected in any of our other hospitals. If we go to the next slide, this is just projected out. You can see where we're at. Again, there's 3 consecutive history years. We had 124 organ donors in 2017, 130 organ donors in 2018. We're projected to be ahead of 2018 as we finish out 2019. And the bottom one there is 2016, where organizationally we historically ran in the upper about the mid to low 90s overall. And then the bottom you can see just kind of projected out number of total tissue and eye donors. We're seeing off the chart record number of tissue and eye donors this year in 2019. So when we think about the early referral, we know it all starts with the defined clinical triggers that we have in place. And on the left-hand side of your screen, you'll see what we currently have in place. And then on the right-hand side of the screen, you'll see our newly approved clinical triggers that we've vetted through our hospitals and internally and externally, and we're preparing to launch those new clinical triggers. So we were finding we weren't getting involved early enough in the process with our current clinical triggers, which is, as you can see on the screen, is a patient on the vent, GCS of 5 or less, no continuous sedatives or paralytics, and all to be made within 1 hour. And then the additional ones, obviously, calling if the family brings up donation, brain death testing order, or the decision to withdraw care. So thanks to several, probably of you on this call and throughout the OPO community. As you all know, it's a very sharing community, and I was able to obtain about 10 different suggested clinical triggers that other OPOs have in existence, and we were able to look at those and find what's going to best work in our service area. And so again, on the right-hand side is our new clinical triggers that we're preparing to launch, referring all ventilated patients within 60 minutes of meeting any condition listed below. And then we have a DCD area focus, the DCD potential, anticipated family meeting to discuss, and that's any GCS, end of life. We actually recently removed the palliative goals because end of life and palliative we found were too similar. If deceleration of care is taking place with vasopressor change, code status change, etc. For brain death potential, GCS of 5 or less, off paralytics, or when brain death testing is planned. We still are keeping the family mentioning donation. Catchy phrase that we obtained from one of the OPOs, wait before you extubate. Make sure all imminent deaths are being referred regardless of age or diagnosis. Please refrain from mentioning donation or even our OPO's name. Evaluating all donation potential, and then obviously the clinical trigger. So why we feel that this is imperative that we launch is, again, we're not being involved early enough. And we've already had twice this year where families when approached about DCD, stated they would have donated if they knew the day before about the option of donation, but right now they're done. And so we knew we had to get involved earlier, and the only way we can start that process by having those conversations and educating about our new clinical triggers and redefining those. So the few sort of observations that we're seeing and why we need the early referral, we're hearing loud and clear families are making decisions earlier to withdraw life-sustaining therapy. These aren't things that families, are saying, yeah, we want to withdraw, but we want to do it 2 days from now. Families are literally saying, like, we want to do it now. And with our current clinical triggers in place, with the withdrawal being one of those clinical triggers, we were getting involved too late, and basically we were having to scramble to approach the family and really sort of derail the process that they had in place for the withdrawal to take place. I just talked about they want to do it now. We're seeing a huge increase in DCD opportunity. I think right now we're running about 26% of our overall donors are DCD, and that's drastically increased, as you saw from a few slides ago. And the other piece is, once the referral has been made to us as the OPO, everything's really in our court. And the one thing I failed to mention is that going from our current clinical triggers to our new clinical triggers, through death record review, it's been determined from our quality team who does that death record review process that approximately we're projected to see about an 83% increase in ventilated referrals just from those clinical triggers. And so that's a big number. And one of the ways we're trying to get ahead of that is we actually offers have been accepted, and there's a couple still going out for clinical responders. Historically, clinical response has been done between our hospital development staff, our family service staff, and our organ recovery team. And so having dedicated people to be able to go out on these referrals is going to be instrumental as our donors continue to increase. And so that's a big thing, and one way that we're trying to be proactive ahead of all of this. So nothing staggering here from what I've already discussed, but really a key takeaway is I really encourage everyone to look at what your current clinical triggers are, and determine if there's a revision that needs to be made overall. And there's my contact information if you have any questions. And I know there's going to be a Q&A session as we move towards the end. But I would like to now turn it over to our colleague, Anne.
Thank you, Andrew. I think that's amazing information that you gave us about increasing 83%. That's huge. So thank you for that. As Kathy mentioned before, I'm Ann Willingham. I'm a donation system specialist with LifeGift in Fort Worth, Texas. And as one of the 58 organ procurement organizations in the country, LifeGift serves over 200 hospitals in 109 counties in Texas. Today I want to discuss how to assure timely referral notification in our donor hospitals, because without the referral, let's face it, there is no donation. So the referral is critical for, it's the critical piece for donation, and it's imperative that we as OPOs assure our partners in the donor hospitals understand the logistics and impact of timely referral notifications. So as Andrew stated a few minutes ago, working with your hospital specifically to create your clinical triggers and disseminating that information to the hospital is really a proactive way to support the triggers and making the process run smoothly. So I'm going to go back to basics about hospital development and how hospital development can really get involved in making the referral process go smoothly. So there are several ways that the OPO HD coordinator can assure timely referral notification. As any other aspect of hospital development, the referral process starts with the basics of education, collaboration, planning, and implementing strategies within the system using your key hospital personnel and donation hospitals within your hospital system. So I'm going to start with education and talk about different ways that you can provide education to your hospital partners. There are you can talk to your critical care and emergency department directors, arrange some time to visit with the staff briefly during the regular scheduled staff meetings. It's a good opportunity for a quick overview of the triggers and to answer specific questions about the processes or concerns that the staff may have had on a particular referral. Also, meet with your hospital educators. That's key. Arrange for a time to set up your new nurse orientations. This is a great opportunity to give an overview of the entire organ tissue eye donation process and dispel any myths about the donation process and relay vital information about clinical triggers. Critical care classes. This is also a great opportunity to get with your educators in the hospital and discuss being part of the in-depth donation process instruction in the ICU and emergency departments with their frontline staff. You can, at that time, go over case studies and include information about timely and missed referrals and the outcomes for each scenario, and purposeful rounding. I like this because this is impromptu education while you're visiting the ICU staff during your regular rounds. Take opportunity to discuss timely referrals, answer questions about particular referrals while you're on site in real time. And so for the OPO staff who will be responding to those referrals, always thank the nurses for calling in a timely manner and show them in real time how their timeliness benefits the entire process of donation. Case follow-ups. This is an incredible opportunity to share outcomes and be able to share specifically the importance of the referral and how many lives were saved and affected by their referral call. Another assurance to timely referral notification is to work as a team within your hospital. Working solo simply does not work. You may be able to educate the staff, but if you don't have a collaborative approach with leadership and frontline staff, a huge piece of your efforts in the hospital will be missing. So I'm going to talk to you a little bit about the collaborative team approach for successful hospital development. First of all, you're going to work on these key donation champions that I have listed for your collaborative team. Of course, your team does not have to be limited to these players, but this could be a good start for getting people together. Please don't forget your physician champion. I'm not sure why that was omitted from this slide, but my apologies for that, because your physician champions will be key in bridging the relationship of their colleagues to the donation process. Also, include executive leadership from the hospital. They can be the ones to expedite policy and process changes if needed within the hospital setting. Get your ICU, ED, and OR managers and directors involved because they know how their units work and they can help determine ways to navigate the changes within their area. The educators, as I mentioned before, they can add the OPO hospital development piece to their educational opportunities for the staff. And quality. This is huge. Your quality department should attend your collaborative meetings to understand the impact of data as it pertains to CMS regulations and also to their hospital donation program. And this is a new one for the last decade. It's become increasingly important to include your IT department in your collaborative meetings for the hospital. The IT department can assure that the electronic medical record prompts are there to support clinical triggers, and it also helps when they are part of the collaboration to grasp the importance of timely referrals and the impact on the donation process. Chaplains and social workers play a huge role in the donation process, and of course their input is very important to the collaborative team. So it's important also the members of your collaborative team are passionate about donation. So as a HD coordinator for the OPO, take the time to listen to the stories that the team members have to share about their connection to donation. Work with the collaborative team to support their own donor memorial event in the hospital. This will spread the passion for donation throughout the hospital like wildfire. Also, you may periodically want to invite a donor family or recipient to come to the meeting and briefly tell their story of hope through donation and transplantation. Connecting the collaborative team to a purpose. What better way to assure timely referral notifications? Also, include your hospital champions or your collaborative team members in OPO-sponsored meetings, either locally or on a national level. This will ensure that they're inspired, and your hospital champions will be able to educate their hospital even more. So now that you have the basis of education and collaboration, let's discuss the nuts and bolts of how you can use these tools to drive successful timely referral notification. One of the key functions of your collaborative team should be to discuss data, drill down information regarding timely or missed referrals to the OPO, unit-specific concerns, and create a plan to resolve issues within the hospital or OPO environment. I'd like to talk specifically about working as an OPO hospital development coordinator with CHRISTUS Mother Frances Hospital in Tyler, Texas, where we specifically reviewed data and dashboards in our monthly collaborative meetings. We discussed possible reasons for untimely or missed referrals being either educational needs for the staff, concerns with timing that it takes for bedside nurses to call in the referrals, and the staff's real understanding of the impact of missed or untimely referrals. Once we understood the real issues, what we did in this collaborative meeting was to set our aim. A good aim is specific, measurable, and addresses how good we want to be in what time period and for what system. So the aim that we devised was to have 100% timely referral rate and no missed referrals within 3 months of implementation of the BPA or best practice alert in the neuro ICU for that particular hospital. So to begin our project, we reviewed the data, which Mike will share in her portion of the presentation. We set our aim and began with IT by developing a BPA or best practice alert in the hospital electronic medical record. When the bedside nurse documented the patient's GCS or Glasgow Coma Scale and vent status, if the patient met the clinical triggers, an alert would notify the nurse to call the OPO. After several months, we reviewed our data and found a significant drop in untimely referrals and no missed referrals. As part of the project, we also looked at possibly reassigning the referral calls to be made by the charge nurse or health unit coordinator, freeing up the bedside nurse for patient care. We tested the changes by meeting with the bedside nurses and charge nurses to assure logistical flow and that the processes were working well within the unit. As a result of the best practice alert, the collaborative team moved forward with the next projects, and out of that effort, the iReferral was born. It's important to know that the process of continual quality improvement did not stop there. It's a constant cycle of education, collaboration, and implementation of new ideas to make the referral process in the hospital run smoothly. So from the OPO standpoint, hospital development is key to assuring timely referral notification. By receiving the notifications appropriately, the OPO can, in turn, provide prompt service to assess potential donor suitability, understand the care team plan to provide a smooth transition to family support and donation. Now it's my privilege to introduce Mike Eckhard. I had the incredible opportunity of working with Mike at CHRISTUS Mother Frances Hospital in Tyler and getting to see her in action. From the hospital perspective, Mike was the driving force for creating new and innovative ways to implement the BPA into their EMR systems and beyond. Mike was key for spearheading the iReferral project within their system and making incredible strides in revolutionizing the referral process. Mike, I'm turning this over to you.
Thank you, Ann, and thank you very much for all you've done for us here. I can't reiterate strongly enough what Ann is saying about the relationship between the organization and the OPO. That relationship with Ann being on site when she was still here in Tyler with us, that was one of the huge keys. And I just can't tell you strongly enough what a difference that relationship made in helping us move forward and looking at our data on a routine basis. That is what got me involved in the first place, that allowed this entire process to work its way through. So it takes a team, but the commitment that Ann demonstrated to our organization is what really got us moving. So here's, again, the collaborative team. You have to be passionate about your donations. Engaged. You have to be able to embrace change, because When you do the same old thing every day, you're going to get the same old outcome. So you have to have people that are not afraid to say, hey, what about? And how can we make that happen? And I think that was pretty much our key. You have to look at the quality indicators and determine what it is. What's not working well? What can you improve? And then you have to have somebody that believes in the whole process of project leadership and project administration to help drive it. That it just all works hand in hand. So interpreting our data for the hospital, that was always a very, very fun meeting when Ann was here and would bring our data. We invited members across the organization. They may not have even been involved in anything to do with organ donation, but if they ever expressed any kind of interest, we added them to the team. So our chief quality officer, our chief nursing officer, somebody that would come and listen and be able to understand the data. And sometimes we had to explain it to them. And that was okay, because once we got their buy-in, it really changed things. We had a very, very strong nurse leader in our med-surg ICU who helped us with this program very significantly, and her engagement and involving her staff really, I think, was part of the key with our success with this. So initially we were a whopping 82%, which might sound good to some people, but it's not good if you're the one waiting for an organ. So our goal is 100%. I've been told that's very unrealistic, but I don't see how it is, because we have people waiting and needing these organs. So that's where we set our goal, and that's what we have striven for since day one. So this, why in the world were we missing that 18%? So I went and did a GEMBA. I went and sat in the ICUs and I talked to the nurses and asked what were the things that were preventing them from timely notification. We looked at the fact that here in Tyler, Texas, we have a large population of novice nurses. These fresh out of school, or perhaps 1 or 2 years experience in the med-surg units and then coming to the ICU, they don't have a strong knowledge base to identify when a patient becomes a potential donor. They're overwhelmed by the situation, and often they just don't see the key changes that are happening. They're also caring for an extremely ill patient with very high acuity. They're busy, busy, busy. In addition to trying to care for the patient, they've got family dynamics going on. There's constant changes with that patient in what all is going on. And here, physically, we have 3 ICUs located in 3 separate towers within our hospital. So there wasn't a real strong support network to help them advance their skills to where they'd even be able to recognize this. Then for the ones that did see it, we had the issue of moral distress. Nurses go into nursing to save patients' lives, pure and simple. And yet here they were being asked to say, oh, I guess this patient isn't going to make it. I'm the one that has to call we use Southwest Transplant here, but I'm the one now that has to make that phone call to Southwest. Am I giving up on my patient? And what if I'm wrong? What if I call and this patient really isn't even ready to become a potential donor? And is it legal for me to make this call? And what if I don't agree with transplant anyway? I think all patients should be able to keep their organs, and we should never do transplants. We had a lot of that kind of discussion with those nurses, and so there was a lot of moral distress going on. Then as Andrew talked about how important it is to make a timely referral, we have got to make sure that we have all of the processes in place to maintain those organs so we get a quality organ at the end of the deal. Because if we drop the ball and we don't maintain, then we've put everybody through an awful lot of drama, stress, moral dilemma for nothing, because then the organs aren't even usable. So very, very complicated. And we had all of this knowledge after we did the GIMBAs and the workflow analysis to say, now what? Now what are we going to do to help remove these burdens right here? So what we were able to do is we took our project, and the goal was to successfully reduce the amount of time the nurses spend away from the bedside to comply with reporting this data, and increase our timeliness of referrals by the use of our electronic medical record. It can take a nurse away from the bedside for 20 to 30 minutes if they have to start from scratch to call that information in to the organ procurement organizations. They don't have time for that when they have a critically ill patient that we're needing to make sure we maintain those organs. So what can we do to help with that? And that's where we wanted to work on the iReferral piece. So what if we got out our magic crystal ball and said, what if we created an alert to remind the nurses when it was time, when that magic bullet happens and now this patient qualifies? What if we can create an alert to at least give the nurse that reminder that it's time? So we had to define who those key players were to make sure that the ones that were going to be using it understood all of the details. We needed to connect the IT department with the nursing staff. So the cool thing is that I am bilingual. I work in the operational side of nursing, but I also live in the IT department. So I work very, very closely with our IT folks and our electronic health records. So I knew a couple of them that would be awesome advocates to work with us on this. So I started inviting them to the meetings and letting them hear where we were and what we were hoping to achieve. So because of having the right people at the time, it really made a world of difference for us, and they jumped on board and helped us immensely with this. So what we did was created flow sheets. The nurses are already documenting within our electronic health record the Glasgow coma, so we knew when there had been a change and was a patient on event. So we put that in place. If the patient met those criteria, then we got an alert. This was our best practice alert, our advisory, to tell the nurse the patient has now met the criteria. It's time to make that phone call. And we put the phone number right there to remind them, and they were able to document here that they had made that call. But again, that call takes time. Anyway, we also created a little bit of a problem with that, because I'll back up and show you this other slide, because here this is the modified, this is version 2. We weren't asking has the patient had a neuro event, so we had patients that were in the ICU that had had a surgery, and they had we were very optimistic that they were going to be awake in a little while and alert, and they would never be a donor at this admission. But we were getting a bunch of false triggers because we forgot to ask if the patient had had a neuro event. So when we went back in and added that, we got a very realistic number of alerts that were then firing, and our nurses were much happier because they weren't getting alerts and we weren't making phone calls to Southwest Transplant inappropriately for patients that were not really going to be potential donors. So we had to work with the frontline staff in the ED, the ICU, the managers, directors, educators, and of course the physicians. We have a couple of physicians that are really passionate about this, and they're terrific advocates to help us and look for opportunities. How can we make it even better? So BAMO, this is what we were getting with our BPA overload, because again, we didn't have the neuro event question. So think of a patient that just had heart surgery, and those nurses were getting this alert over and over and over. So they just wanted it turned off altogether, which we did because we sure don't want to give them BPA overload. But once we figured out what the problem was, then now we have them back on board. So we had to define it, which you know how it is. It's continuous improvement. You get started, you decide if that's going to work for you, and if not, how can we fix it? So we just continued to modify our process until we got to where we are today. So what came of it? Well, look at how cool this is. So we started with our timely referrals that just pretty slow moving. 2018 we were at 99%, and we were given that beautiful recognition that we hang in the hallway here. So we have a central area that is focused on organ donation, and this hangs there, and it creates a lot of discussion among patients' families as they walk through there and see it. So I think it's pretty important to help us continue to get the word out. And we're not doing it for plaques. We're doing it because it's the right thing to do. But it's nice to have that physical presence there in the hallway that people can see that we truly do care about this. We take it very seriously. So you can see that our initial call went up significantly. One thing that we had identified was that sometimes there was this patient's family is interested in making this patient a donor, but it's not time to extubate yet, or they're thinking that they may want to, but then somehow the ball gets dropped. We've identified this patient as a potential donor, but they're not extubating now, and we need to remember to call Southwest back before they extubate. Well, a couple of our nurses at the bedside said if we just had something there on the tube that we can see before we extubate, that'll remind us that we have to make that second call. So as part of a rapid turnaround, rapid improvement, they suggested we put this green tie on there to indicate a reminder to them, don't extubate this patient until you call Southwest back. So that went into place practically overnight, I believe. Ann was good enough to find us some green ties that we could put on there that were right there, physical presence for the nurses as a reminder. And it's worked like magic. It was just something that simple by simply putting a green band on the tube to remind them, don't extubate until you make that second call. So from there, our plan was to automate this, make that initial call automatically, send information through the electronic health record from our system to the organ procurement organization system. So that's kind of phase one, moving into phase two of our program. So that's it from Mother Frances with all the cool things we've been working on here.
All right. Thank you, Andrew, Ann, and Mike, for such an informative presentation. Before I turn it back to Kathy for questions, I'd just like to remind everyone that if you do have any questions for either of our presenters, please be sure to submit them using that chat feature. Just as a reminder, again, it's located in the bottom left-hand corner of your screen. Also, during the Q&A session, I'm going to have this poll up. For those of you who are listening in a group, if you could please complete the poll and let us know how many people are participating in your group, that would be greatly appreciated. With that being said, at this point, I'll go ahead and turn it back over to Kathy.
Thank you, Deanna. We have a question from Mark Gravel. And we'll send this out to Andrew and Ann. What percentage of imminent death notifications do you respond on-site to evaluate? And what is your average imminent death notification response time? Andrew?
Yeah, it's a great question. I will say that our policy is to respond to all of our imminent deaths. So when we receive those to show up, I always say if the hospital's taking the time to make the referral, our job is to show up, and we do so within 1 hour of receiving the imminent referral. Now there are some caveats to that, meaning looking at our service area, we're fortunate that about 80% of our ventilated referrals come from within a 15-mile radius from our office here in Central Ohio. When we start to go outside of Central Ohio into our other parts of our service area, the response time obviously is going to be longer just based off of the drive time. Our maximum drive time is approximately, the furthest out hospital, about 2.5 hours to 3 hours for a ventilator referral. So we do our very best to show up and show up within a 60 minutes.
Ann, do you want to respond?
Yes, Texas is a bigger state than Ohio, so I'm going to respond in the Texas style. We pre-screen our referrals through our call center, and our response time for the larger metropolitan areas is, of course, an hour, depending on traffic, of course. In the rural areas, we have a little bit longer response time, but we try our best to respond to every single referral that's called in as appropriate, because like Andrew said, they took the time to call in the referral, and out of respect for that, we go on site for every referral that's legitimate.
Okay. Yeah, I'll also add one other thing. We also, about a year and a half, maybe 2 years ago, we put into place referral response guidelines, also something that another OPO shared with us. And so we have different buckets, per se, of how we respond depending on what the scenario is of the referral and who we send. So that's also been extremely helpful when we're deciding how and when we respond and who goes.
Here's another question. Where do you put the green tie, and what does it look like? Mike?
Yeah, it's just a simple little green twist tie like you would use for electronics, and it just went right around the tube, right in front of the patient, right by the patient's mouth. It wasn't something that we ever drew attention to because we didn't want the family asking what it was. We wanted something that was a physical reminder without drawing unnecessary attention.
Okay, thank you. Another question, Mike, for you, I think. This comes from Diane. Have you investigated a best practice alert that prompts with a withdrawal order? She said, we are good with the initial call, however, we'll sometimes miss the extubation, but the green ribbon on the vent sounds great. So do you have you done any kind of BPA with a withdrawal order from a physician?
No, we haven't. To get a BPA anymore, now that our system continues to grow, we have a pretty strict governance process to go through to get a BPA or to even modify an existing one. So this was something we could do very quickly, and we've not had any issues with it, so no one's reached out asking for a BPA, but I think what we're doing is working, so for now I'm not too sure we'd be able to push one through if we chose to go that route.
This is Ann. Can I add to that also? I wanted to add about it's actually not a green ribbon. We worked on this with the collaborative team as well because we had to get infection prevention involved in the respiratory therapy department because we didn't want to do anything with that project to interfere with the ventilator or patient safety. So we came up with, it's a green zip tie. I just want to make sure that you understand it's not a ribbon because for, like Mike was saying, it had to be something that was not questionable from the family. It was very small, and it just sent over the circuit of the vent in front of the patient's face on the ventilator. So the staff were the only ones, the respiratory therapy staff and the ICU nurse staff were the only ones that really knew what that was, and of course the doctors too. So the frontline staff who were giving patient care knew what that meant, but it wasn't advertised in the hospital what that meant. Does that make sense?
Yes, it does. We have another question. I think this probably goes for Ann and Mike. Someone wants to know how much did this cost the hospital to build and now maintain, and how much does it cost the OPO annually to maintain? And I don't know if that's something you want to discuss or not.
There's no cost associated with it. It's one of those cool things that you just involve your IT team. Takes a little time to develop, but there's no cost associated with it.
Okay. Ann, how have you found champions in the hospital? Ann and Mike and Andrew, all three, I guess. How have you found champions in the hospital? How did you identify them?
I'll start with that one. I met Mike for one, and it kind of grew from there. She identified people herself that she knew in her team at the hospital and got them involved. But it starts with one person and developing that relationship and being able to spread that.
Yeah, I have to agree with Ann. It's all about the relationships and coming and presenting. She presented every time we had a new class, onboarded a new group of nurses. Ann would go and do a presentation. And then I followed her because then I did a totally unrelated presentation. It's just that I happened to follow her on the agenda. So I was able to hear what she was telling the nurses. And then they were talking about data at some meeting I was at, and I live in data, so I got myself invited to that meeting, and it just kind of grew out of there. But if Ann wasn't here and so actively involved in our hospital, we never would have gotten to the point where we are now. It's all about the relationships.
Okay.
Yeah, I would have to say, first of all, thanks to Mike, to you and your hospital, and also to the OPO, your local OPO, for launching this. This is going to make a tremendous impact, I think, across our country. And we're looking to launch something like this with one of our hospitals also that uses Epic. And in doing so, it's really about finding the key stakeholders, the right hospital to launch at. We didn't want to launch with a hospital that's too big or too small, but sort of right in the middle and is completely bought into to donation, has the supportive culture for that, IT, et cetera. And so we're excited to, as we move into 2020, to hopefully be able to launch with one particular hospital, and we're in the planning stages. So huge thanks to you guys for really setting the tone for all of us and setting the going out and first to do this. And so we look forward to seeing this grow across the country. But it's all about the relationships as you established, and also just continue to build upon what's already there.
I have another question. They say it sounds like your collaborative team and the meetings were very important in the planning. How did you assure active participation in the planning meetings? And so how did you ensure that people were committed and able to continue on with the planning sessions?
Yeah, I would like to answer that. It's difficult because in this day and age, everybody is so busy, and you can set meetings. We set them for the year in advance, once a month, and invariably people forgot about them. I mean, because it's just the nature of the business. You get busy. So what I would do is I would show up in the hospital about an hour and a half before the meeting and just go visit the key players on our collaborative team, and friendly reminder that we're having the meeting and where it is. And just, even though they've got it on their calendar, it helps to have that presence, and people would break what they were doing and show up to the meeting.
Let's see. I had a question here. I'm trying to find it. How did the frontline staff respond to the best practice alert, and how did you get their buy-in to that process?
Well, we presented it to them before we went live. We actually had bedside nurses help us design it and ask them, when's the best time for this to fire? Because within Epic, we can have it fire at any point. We could say fire it as soon as the nurse clicks in that flow sheet, we can make it fire. Or when they go to close the chart, or, any time we can have it fire. So we had them work with us to determine the best place, the most effective place for them to be able to have it fire, and then to be able to click on it to document that they had completed the referral.
Okay. I don't see any more questions. Deanna, I'll turn it back over to you.
Thank you, Kathy. Well, at this point, I'd just like to once again thank Andrew, Ann, and Mike for joining us today to share your expertise on this topic. And additionally, I'd like to extend a sincere thanks to Kathy for taking the time to moderate today's webinar. To all of our participants, as always, we thank you for your time, and we hope you enjoy the rest of your day. Take care.